Thank you very much. Once again, it's a great pleasure to be here. I would like to thank the organizing committee. I have no disclosures. Treatment of rectal cancer is an individualized treatment, and you need to play chess. There are so many different tactics, so many different options. And what we are looking for is better short-term outcomes, long-term oncologic results, and better quality of life. And doing the mesorectal excision on a correct plane showed us how we can get better oncologic outcomes, and this changed the rectal cancer surgery again and in a very good way. And there are now different options while we are doing the surgery: open, laparoscopy, robotic, and transanal TME. So is it really matters to have a long incision or a small financial incision, or without any incision and without any stoma, as we listened this morning? So I'll start to compare the open versus laparoscopy. And when the laparoscopy came out first, there are so many criticism regarding the new technique and the learning curve and blah, blah, blah. And there are many studies, especially I took the randomized studies, and as you see here, it is all 2000, start with the 2013 to 2015. And when we look at those four open versus laparoscopic comparison, three of them, Color, Akazok, and Elacart, could not able to show any better outcome regarding the laparoscopic TME when compared with the open one. Only the Korean one showed that it is non-inferior to the open surgery and is good for mid and distal rectal cancer. And when we look at in detail Akazok study, for example, the positive circumferential margin is high, and rectal perforation is again high, although not statistically significant. This is the Korean study, and as you see here, and I'm aware that you know it very well, there is no difference, but this is a non-inferiority study, and randomized study showed it is similar. And there was a systematic review and meta-analysis showing the pathologic outcomes, and it came out that the non-complete mesorectal excision is significantly high if you do a laparoscopic TME during those days. And this is the healed data, and I put my open surgery data, which is nearly 15 years old, and this is the Amjad Parviz laparoscopy data, and this is my laparoscopy data. It is, I mean, if you do a proper dissection, you can achieve as good as healed results, I must say. And when the robotic came out, the history repeats itself. It is a new technique, and then again you see long learning curve, oncologic safety, post-site metastasis was the same problem. And to start with the comparison, there are retrospective and meta-analyses, and all showed similar results in terms of the short-term outcome and oncologic parameters. And this is once again, the Korean group did a propensity score analysis, and they showed that the 5-year survival and disease-free survival rate almost the same, as well as the local recurrence rate. But though they reported during that time that robotic costs a little bit more expensive. And then Sohan Kim group showed that robotic is better, though not statistically significant when compared with laparoscopic TME. And this is the European Rollart trial, and their primary endpoint was conversion to open, and secondary endpoint is circumferential resection margin positivity. Both did not reach statistically significant, although comparison to open laparotomy is more in laparoscopy group compared to robotic assisted group. And this is another study from this country, and again, although not statistically significant, results of the robot is better, although the secondary endpoint was almost the same, only the genitourinary function is better in robotic when compared with the laparoscopic surgery. And there was another meta-analysis looking at the completeness of total mesorectal excision. To start with, the robotic seems better, but there are recent data shows that the laparoscopic results are better in terms of completeness of TME. And there's a recent study published last year from China, a multicenter randomized study, over 500 patients, and the oncologic data regarding the circumferential resection margin positivity rate almost statistically significantly low in robotic surgery, and the complication is low in the robotic surgery group. However, complete resection and quality of resection almost the same, and they concluded that robotic surgery has better oncologic quality and less surgical trauma and better postoperative recovery. And further that, again, from this country, Colorado randomized study published, although it terminated prematurely, the completeness of TME is almost the same, and the colleagues concluded that for the middle and low rectal cancer, robotic surgery did not significantly improve the quality when compared to conventional laparoscopic surgery, although their subgroup analyses show statistically significantly less positive circumferential resection margin in the robotic TME group. When we look at the literature, it is well reported by Wexner and Cuschieri that the spin is almost 80% and conflict of interest is 50% in robotic publication. Moreover, there are some news about in BBC and in Australia and other countries as well. There are some deaths regarding the robot, and one of the consultants argue against it. If the operation was done on a human being, it can be prevented. So it is an important issue. And finally, I just would like to compare the transanal TME with laparoscopy and robotic surgery. There are evidence-based retrospective non-randomized studies and only 2 recently published randomized studies, and there are few systematic meta-analyses. When we look at the European guidelines, it is a very limited indication, very low rectal cancer, high BMI, male pelvis, big prostate on MRI, and post-chemoradiotherapy cases, they recommend doing TME. And this is the report of the international study group, and it is more than 700 cases and almost over 600 are malignant tumors. And when you look at this data, there are positive circumferential margin and missing data, and R1 resection and missing data is quite high, and although they said it is complete and good to do CME. And again, they reported their survival rates, and the 2-year survival rate is 92% and local failure rate is 5%. In Hill's open TME study, it was none in 2 years. And again, the international study showed that the morbidity is 36% almost, and anastomotic failure rate is 16%, which is quite high. Again, looking at the healed open total mesorectal excision. Once again, the urologic complications high, especially when you start doing this TME at the beginning of the curve. And there must be a word of caution. I mean, we must take this step and be aware of the complications. And again, Norwegians do total mesorectal excision quite nicely, because 20 years ago, Hill traveled Norway maybe more than 100 times and showed how to do a proper total mesorectal excision, and their local failure was around less than 4% in 5 years. However, in less than a year, they have 10% local recurrence, and high anastomotic leakage and high mortality, and then they suspended to do it in Norway. Again, there are some other randomized study looking at the functions. Now it is TME versus laparoscopic surgery. There is no change in bowel or urologic functions, but there are significantly better in TME in the sexual activity. However, this is comparing the robotic to TME, and this time robotic is better in terms of sexual activity compared to robot, otherwise almost the same. And now this is the one of the multi-center study just published recently, and it is over 50% laparoscopic TME and TME. And look at the conversion rate. It is significantly high in the laparoscopic group compared to TME group, and although the local recurrence rate not statistically significant, and the outcomes are not statistically significant, just only the conversion rate is different. Again, just recently published the Chinese group. Again, it's a randomized study, and it is over 500 patients, and their complication rate is much more same, no statistically significant difference, and successful resection rate not statistically significant. Conversion rate, yes, there is some difference, but it is less than 1% in laparoscopy group, and they concluded that experienced surgeon can safely perform TME in selected patients. So in the TME, there are some problems: steep learning curve and high rate of intersphincteric resection and impairs outcome, and prolonged anal dilatation. It is due to the anal platform, and the operation time is a little bit longer than usual laparoscopy, robotic, or open surgery. And for the TME, again, we need to standardize the operation. It is a new for all of us. It does not like laparoscopy or robotic. It needs a teaching and training curriculum, and we need to wait the long-term results. And just recently, again, there was a meta-analysis which compares the open laparoscopy, robotic, and TME. Did not include the last recent two randomized study that I showed you. Just look at the BMIs as you see, and these are the results. As you see, the oncologic data is almost the same between the open laparoscopy, robotic, or TME. Only distance to distal resection margin is better in robotic, and conversion to open better in, again, robotic, and the length of stay is better in robotic. And they concluded that robotic achieved improved distal resection margin, achieved a shorter length of hospital stay. Overall, the others are the same. And these are the, again, ongoing TME trials. Within a couple of years, we can have more data to start with. But nowadays, the comparison have problem. There is lack of evidence. Most of studies are non-inferiority studies because the superiority study needs more patient. And when we look at the meta-analysis, most of them case control studies, and most of the comparison was done including the upper rectal cancer. And do not forget that the Asian population BMI is different from the non-Asian population. Yes, indeed, the distal rectal cancer in an obese, previous pelvic surgery, preoperative chemoradiotherapy, high BMI, narrow pelvis male, it is difficult. It is difficult, whatever which approach you choose. So what we have to choose, these are the comparison, and all the randomized studies, concluded with this sentences. It says you can do it by if you are a skilled surgeon and in selected patients. So this is the most important. So this is the egg. There are a variety of types. You can cook the egg. So if you are a surgeon, you have to know every technical details to sort it out. Yes, there is an evolution of colorectal surgery. I'm sure that maybe I can see, but I mean there might be more approach for rectal cancer. And this is the author Schopenhauer says, change alone is eternal, perpetual, and immortal. What really matters is the quality of your surgery. Whatever you do, if you are doing a poor surgery, you will have a poor outcome as documented by this. We cannot change the intrinsic biological factors of the tumor, but we can train the surgeon in order to get better results. And we have to respect the embryological planes, we have to minimize the tissue trauma, we have to minimize tumor handling, and if it looks good as this in the healed specimen, the results will be good. I would like to thank for this opportunity. Thank you very much for having me.